but the psychology is a essential part of pain management.
Mm-hmm.
It was part of everyone's residency when they did pain.
Really?
Yeah, I did a 2 month, I think 2 month rotation in pain. I mean, in psychology, psychiatry,
Mm-hmm.
and a 2 month in addiction, something like that.
Interesting.
Yeah. And the whole exam was full of questions, and my actual practice.
Right.
Um,
So you can understand the psychology
of course,
behind the pain and help manage it.
We refer patients to them, and they refer patients to us.
Well, that's actually, I was wondering that. Do we do that in Kuwait?
We do that in Kuwait. The
Okay.
only issue is that, and this is everywhere in the world,
Mm-hmm.
it's very expensive to have a interdisciplinary practice.
Really?
So the
I didn't factor that in.
yeah, so the difference between multidisciplinary and interdisciplinary is where everyone together are managing the same patient.
Right.
Well, multidisciplinary is when you refer to, like, you work together, but you're referring them. So what happens in general is they get lost in the system.
Mm-hmm.
So you all go see the psychiatrist and then come back to me,
Okay.
instead of us communicating directly
Mm-hmm.
about this patient.
Mm-hmm.
So it happens in Kuwait.
Mm-hmm.
We're trying. Not every hospital has a psychiatrist.
Yeah. Yeah.
Not every hospital has a pain physician.
Mm-hmm.
So sometimes they have to go to different hospitals.
Mm.
But I try to, whenever I have a patient, the first, during the feedback, the first 10 minutes or 5 minutes, I try to spend it on, if I have time, I'll try to do my best, is pain education.
Mm.
A lot of patients say, do you think that I'm just feeling the pain is in my head? I will say, no, the pain is not just in your head. You actually have physical pain, but where does everything go at the end of the day? It goes to
In
your
the head,
brain.
yeah.
So taking care of your brain is an essential part of taking care of your pain.
Do you think that pain is also cultural?
Different cultures actually have different expectations of what pain is. So
Yeah.
in the U.S., for example, when they finish an orthopedic surgery or whatever, they are usually easily prescribing opioids.
Right.
And in some other countries, developing countries, they might go home with NSAIDs, non-steroidal.
Really?
Yes, yeah. Germany, I think, which is of developed countries, and knee replacement, sometimes they don't give strong opioids.
Wow.
And Asian countries as well, I think even in Kuwait, the reliance on opioids is much less compared to the Western society. Yeah.
Really?
So,
That's
so
interesting.
I'm sure there's a bit of culture.
Mhm.
I did not investigate that thoroughly to not make assumptions. But yeah.
It's because a colleague of mine on the wards told me that that someone in his unit or consultant, or I'm not sure, was saying how when, for example, Persian patients, when a Persian patient tells you they have chest pain, that means that it is a massive MI intervene because they tolerate pain well.
Some people tolerate pain well. Yeah.
Yeah.
I guess that could be possibly true.
Yeah. Interesting. I'm sure there's been research done on this. I'm like certain. I should look into it. Now, we mentioned addiction. And I think a big thing that for us juniors that we struggle with, especially with pain, will be, of course, sickle cell anemia. So, so if you can kind of give us first a background of what sickle cell anemia, the management of it, the approach in Kuwait is like.
Okay, so I'm just want to highlight one point. I'm glad you said addiction when you said sickle cell.
Yeah.
Because they're two very different things.
Yeah.
So, and a lot of times we assume that the sickle cell patient is addicted, but that's not the correct thing.
Yeah.
A lot of them are actually in pain and require medication. Some of them do end up getting physical dependence, although if they were managed well initially, that risk is much less than when poorly managed and labeled as addicted.
Yeah.
So in general, I wasn't here a long time ago, but the management is shifting now. And we have a committee from the Ministry of Health.
Really?
From a hematologist, pain specialist, internist, pediatrics, to try to come up with a plan. Because obviously sickle cell, like I have, in the last 2 years, I've seen more sickle cell patients than I've seen in all my practice in Canada.
Really?
Yes.
It's prevalent in Kuwait more so.
Of course, yeah. Because of, we have the culture reasons. In marriages and everything, people get
more consanguineous
yes,
marriages.
So you get more risk of sickle cell. So we're trying to come up with a plan, and a protocol has been established by the Ministry of Health. I encourage every junior or senior doctor to inquire about that.
Yeah.
So in general, what happens is that the patient with sickle cell crisis, acute pain crisis, who comes into the hospital has to manage within the hour with a multimodal approach, and if need be, a narcotic-based IV dosing initially at weight-based.
Right.
And once that is done in the ward, and it's just not a single dose, like every 4 hours, for example, 10 milligram of morphine, for example, maximum, every 4 hours. And if need be, and patient is still in a lot of pain, the old protocol used to say consult anesthesia. Dr. Abdulrahman Faris is the I'm named Norprik here, but anyway, he's the head of the anesthesia department in Amiri. Said that's lacking, so he instructed us to come up with a different plan or a further plan. So what we did is check the updates, and we included the patient-controlled analgesia, which is a PCA, where the patient can give his self-medication. So if he exceeds that amount, then we could consult anesthesia for a PCA.
Right.
Patient-controlled analgesia. Hopefully that will be implemented on all the hospital, and it will help the patients. The key in sickle cell management is to recognize it early and management well to avoid the chronicity of the disease.